Okay, so my topic is PKPD for multi-drug resistant organisms. So whenever you decide to give any antimicrobial compound, and I deliberately use the word antimicrobial because in present ICU we just are not dealing with bacteria, we are dealing with a lot of other organisms, mycobacterium for example, non-mycobacterium organisms, and fungal infections have come a big way, and I believe you have a class somewhere down the line on fungal infections in the intensive care unit. And woe and betide, if that was not enough, I am dealing with a patient who has got trichosporin asahi in the urine, and that organism especially is said to be lethal. And only yesterday evening, late in the evening, I got the sensitivity report to that particular organism, and it is sensitive only to amphotericin B and not sensitive to any other organism. Now, unfortunately, amphotericin B penetration into the urine is negligible, well, very low. Caspofungin, the entire echinocandin, no penetration at all. The penetration of antifungal compounds into the urine is predominantly with fluconazole or other azoles. So I had given a combination of azoles, voriconazole and amphotericin in this patient. But yesterday's report said voriconazole not sensitive at all. So I have got no choice but to hope and pray that whatever little, so I have used the deoxycholate salt, because deoxycholate salt has got nephrotoxicity. So if it is producing nephrotoxicity, obviously I would expect it to go into the kidney and maybe eradicate this organism. What little goes in, I believe that is going to work and maybe clear this organism. So these are the kind of problems that we face in the intensive care unit, and that is why the whole paradigm has shifted from what I spoke last year to this year, and that is why I have tried to make changes in my presentation. So whenever we decide to choose antimicrobial, we use the site of infections, the likely organisms and likely susceptibility, severity of infection. In the euphemism of the medical ID specialist, it is the inoculum of the organism that has gone into the body that has a bearing upon the choice of antibiotics. And obviously the other things are very important, like ability to achieve source control, the side effects and the allergy and interactions. But my topic is properties of the antibiotics, the PKPD parameters, whether the patient is antibiotic is stable or static, whether it reaches adequate concentration at the site of infection, and what are the spectrum of activity. In the next 20 minutes, I hope to deal with all of them. So we have a real big problem. We have real big problem in the sense, where are we? That your problem has become all the more because unfortunately the antibiotics have become resistant to most other, the bacteria have become resistant to most of the antibiotics that you have at your disposal, and the pipeline is running dry. And that's why it is not surprising that if you look in your own ICUs, the amount of antibiotic consumption that used to take place maybe 5 years back is down to around 20-25%, because you realize that there is no point in pumping them with antibiotics, especially if they don't have the sensitivity to that particular antibiotic. So just to go into a bit of basics, when we are become super specialists, we tend to forget certain things about the basics, and microbiology was somewhere deep down in your first or third and second MBBS that you gave the examination. So a little bit of microbiology for you, that this is a gram-positive bacteria which has a cell wall, and above that is a cytoplasmic, underneath it is a cytoplasmic membrane, and that cell wall gives you the classic blue color in the HH stains and usual tension violet stains that you see in the ICU. You get blue colored clusters of pneumococcus, for example. And so cytoplasmic membrane has a tough rigid mesh which is called the cell wall. The cell wall is above the cell membrane, but when we go down, the cytoplasmic membrane and the cell wall is still intact, but the gram-negative bacteria, in addition to that, have an outer membrane. And this outer membrane distinguishes it from the gram-positive bacteria, and that's why you get a typical pink stain when you stain these organisms under the microscope. So this is the gram-negative membrane, and you see in between these two, if I have the pointer please, here this is the outer membrane, and here is the periplasmic space. Now what we would tend to believe that the periplasmic space is empty. But gram-negative bacteria have become smart. They have created this periplasmic space because this periplasmic space contains what is called as efflux pumps, and they have developed resistance to even antibiotics like carbapenems by actively extruding out antibiotics even after they have entered the periplastic space. So that is what I wanted to highlight, that periplastic space is there, which is again becomes one more mechanism of antibiotics resistance, which is again there are plenty of mechanisms, and even one bacteria may harbor more than one mechanism of resistance. We know about ESBS, we know about NDMs and all that, but this is another mechanism in which the bacteria, even after the antibiotics have entered into the beyond the cell membrane, they are actively excluded out, and that is called the efflux of the antibiotics. So that is why the antibiotics that we have at our disposal are generally divided into three broad categories: ones that target the bacterial cell envelope, those that block production of new proteins such as protein synthesis, and those that target DNA and DNA replication. So you will understand why I have shown this definition, that these antibiotics that target the bacterial cell envelope, they actually call cell lysis, and when they cause cell lysis, the bacteria die. And that is why those antibiotics which act this way are mostly bactericidal, right? So when they are involved at the nuclear level, at the formation of new proteins or DNA, what they actually do is they prevent the duplication or multiplication of the bacteria. So in that sense, they tend to be bacteriostatic. So I think this should be very clear to you, that when you decide and when you know the mechanism of action, you can even predict what this antibiotic is going to do to the bacteria. So that ones which affect the cell envelope are the classic beta-lactam antibiotics. And I remember the microbiology professor telling me in the class that when you decide to give antibiotics to a patient, your number one choice has to be beta-lactam. And why beta-lactam? Because number one, we have got plenty of experience in using beta-lactams. Penicillin was discovered way back in 1939, and since 39 we have got variations of beta-lactams. First the cephalosporins came during my medical college days. Subsequent to that, the fluoroquinolone came, and 99 a big bomb was dropped when we got imipenem. 2002 another big bomb, now meropenem, and then of course zosyn came in at around the same time. We were living in an area of plenty, whatever dose, whichever way we were giving these drugs, our patients were getting better. So that was a honeymoon period for that. And by the time 2006 came, we started getting resistance, and I have the dubious distinction of using colistin since 2006. So that is how it has evolved. So beta-lactam antibiotics have stood the test of time, but now we are dealing with an era which is perhaps being called as post-carbapenem era, because I'm sure all of you must be having 80 to 90% resistance to meropenem and imipenem in your, especially for gram-negative bacteria. We'll be talking more about that later. Vancomycin, daptomycin, of course, we'll talk. Block protein production, rifampicin, aminoglycosides, macrolides, streptogramin, that is sulbacin, linezolid, and that target DNA and its replications are sulfa drugs, quinolones, metronidazole. So now you know which are the drugs which are cidal, which are the drugs which are bacteriostatic. But again, when I come to decide about what antibiotic to give to my patient, sometimes I should pause and ponder, should I be using antibiotic at all? There's so many times I get a patient of AMI, I get a patient of CVA with a stroke or something, and the counts are 22,000, 25,000, 30,000. Now the patient had an MI while sitting at home, and you mean to say just because his count is 32,000, do I pump him with antibiotic? Patient had a bleed at home, got into the hospital, but there was no bed elsewhere, and these patients may need airway protection. They get admitted to the ICU. And the moment they get admitted to the ICU, the first thing that a doctor in the ICU, or for that matter even the parent unit doctor says, ICU my patient, uska antibiotic kaise na दूं मैं? So you start, at least one antibiotic is given to this patient. So these are conditions which I will talk about, the non-infectious cause of fevers, and sometimes an antibiotic is just not necessary. And nowadays especially I have made a protocol in my ICU. Those stroke patients who are thrombolized and they come to my ICU, they don't get any antibiotic. My nurses have been told patients who bleed in my ICU, I am talking about cerebral bleed of course, they have a temperature of 38 degrees centigrade, don't give paracetamol to these patients. Accept it. Because even if you give paracetamol to the patient, the fever is not going to come down. The fever is because of the blood in the brain and not because of any pyrogens which is there in the body. Okay, so yes, after that, if suppose we decide the antibiotic has to be given, I have other questions in my mind, and that is, should I use a combination? what are the dose that I should use, and how long should I be using it. Hopefully by the end of my lecture, all of you should be clear in your mind what are the answers to this question. So these are so many non-infectious causes of fever. You can have these presentations later on for you to know what are the various causes. Pulmonary thromboembolism is one thing, and for those who have been working in the ICU and the patients have been lying there for a long time, think of paranasal sinus, think of middle ear. Sometimes for some reason or the other, for different reason, the patient gets a CT scan of the brain and you tend to get a report which says the paranasal sinuses are full of pus, the middle ear is full of pus, temporal lobe is involved, that kind of stuff. These are those patients who have seemingly improved, but they are just not leaving the ICU because they have a niggling fever. They are just not coming out of pressure support of 8.5. You just can't get down below that. So these are the various reasons. And most common reason that I have in my practice is a DVT. DVT patients tend to have fever which doesn't respond to anything unless you of course treat the DVT. And the DVT is not in the lower limbs. The DVT is somewhere up there, the axilla, the subclavian, where you have put the central lines. So these are certain things that you should remember. Drugs, I'm afraid, they can themselves contribute to fever, and these are the common things. Antibiotics that we use all the time, sedatives that we use all the time, antiepileptics, every time all patients of them are on levetiracetam. Diuretics, we are very fond of using diuretics. Non-steroidal anti-inflammatory drugs, that is something we are not very fond of, but they also by themselves can produce fever. The others are uncommon causes, but the common causes are these, and you would realize that yes, these are used rampantly in the ICU. So this should be something which should be kept in mind before jumping and treating the fever in the patients with ICU. Treat the infection, not colonization. I'm afraid Dr. Kilnani will be coming after me and he'll be speaking a lot about colonization. He has written a few articles on colonization. If the colonization is present, these patients are likely to be infected also, and that is why you should do surveillance culture to know what are they colonized with. I am having a different school of thought. I always say that colonization is there, but that doesn't mean that I pump them with antibiotic. A lot of argument I had over whether I treat ventilator-associated tracheobronchitis or I treat a VAP. Now, if suppose just because from the trachea I am getting an isolate, do I need to treat it? Unless, of course, it is accompanied by increase in the oxygenation, increase in the purulence of the secretions, presence of a new onset infiltrate in the chest X-ray. If these things are not there, do I treat a ventricular associated tracheobronchitis? Okay, even though the trachea is involved, do I treat it? Possibly I would be a bit conservative there, and I would say probably I will wait, I will not treat this patient. But people say that VAT is just a precursor of VAP, and so that's why the sooner you start treating, the better results you are going to get. So this is the dilemma that you have to face in your clinical life all the time. So the same thing goes about the urinary tract, and I have not discussed so much about it. But yes, there are occasions where you are dealing with a true bacteremia, virulent organisms, Klebsiella, Staph pneumoniae, Pseudomonas species, Staph aureus, Enterobacteriaceae, and most importantly Candida species. You just can't ignore Candida in blood. If you are getting Candida in blood, you have to treat it. And when you treat it, obviously your treatment would depend upon what is the hemodynamic stability of the patient. If the patient is unstable, patient is on ventilator, patient is sick, you don't have a choice but to give them echinocandins. I do agree with you, echinocandins are very expensive drugs. They have to be given for a long period of time. But you have to save the life of the patient, so you don't have a choice. And of course, predisposing factors such as immunocompromised state, prosthesis, like for example, there will be a knee transplant in the patient might be having a prosthetic valve. In those situations, not only perhaps you might have to take a decision about whether you remove the prosthesis, but even after having done that, you have to treat the patient for a long period of time, and that is something like 6 weeks in these patients to really eradicate the infection. That is very, very true with coagulase negative staphylococci, which are generally discarded or ignored by us as contaminant in the microbiological culture. Also generally regarded as contaminant. But if my patient has a prosthetic device and that would include a central line, I would give them due respect and possibly treat them. Normally I will not, but in these circumstances perhaps I'll give due respect to that and treat them. So finally, the important thing is optimal dose. We know everything about antibiotics, but we don't know how much to give, and this is something which has been going on from my internship days my senior would tell me, give cloxacillin, give ampicillin, I would know 600, 500 milligrams, 600, and I would write it. So that is why the antibiotics nowadays, when we talk about them, we talk about concentration independent killing and concentration dependent killing. I'm sorry, I'm just jumping around. So concentration independent killing and concentration dependent killing. So we'll be talking more about that in the due course, but basically we are trying to say that do I need to keep the concentration standard or normal throughout the day, or do we just want to reach the concentration one time of the day and hope that there is a post-antibiotic effect that will take care of the drugs, that will take care of the bacteria later on. So these are the kind of dosage that we have to go in for to decide what is the quantity given. But the crux of this lecture is this particular graph that you need to see. What you're seeing there is this is the axis, this is the y-axis, is the drug concentration, this is the time. So when you give a drug, then initially the drug concentration goes up to what is called as Cmax, then it comes down to the trough, and this area which is occupied by this curve, that is called the area under the curve, and this is the dashed line which is suggestive of minimum inhibitory concentration. I believe all of you are of that standard that I don't have to tell you what is the actual definition of that. But when we talk about the efficacy or the currency which we use to tell how potent the antibiotic is, we use certain words, and in that certain words, the first is Cmax over MIC, the second is AUC over MIC, and the third one is time over MIC. So but what you need to know is that MIC is the denominator in all the three. So MIC obviously has a very important role, and I'll be talking more about MIC in the next few minutes. But you need to know that Cmax over MIC is the indicator of potency of those drugs whose effect depends upon the maximal concentration that they are able to achieve at a particular point of time, obviously just after the drug infusion has taken place. So the drugs which belong to this category are the classical aminoglycosides, and you will realize that is the reason why aminoglycosides are given as a one big dose, and just one dose is given over 24 hours. Then we have the time dependent or concentration independent. The classic examples are carbapenems, and you need these drugs concentration to be well above the MIC, and that will be 4 to 4 times at least over the MIC. And this concentration, which is 4 times above the MIC, has to be present for a good period of time. Now for carbapenems, here it is written as 30%. I generally go for 40% for carbapenems, 60% for cephalosporins. That means the concentration of carbapenems needs to be 4 times more than the MIC for 50% of the time of the dosing interval. So I give meropenem for 8-hourly doses. My concentration of meropenem should be 4 times above the MIC for at least 4 hours, and that can be achieved only if I give a infusion for 4 hours. So now you understand why all the ICUs have moved on to prolonged infusion of antibiotics. But then there are certain antibiotics which depend upon the total concentration that the body is exposed to. The total concentration would be in the concentration and the time. So this is an integration. So when you integrate these two factors, the total concentration and the time, you get what is called as area under the curve. And the classic example of area under the curve is colistin. And we'll be talking about colistin in due course of time. So hopefully this picture is clear. I'm not going for the definitions. I hope that you know all the definitions. What is MIC, what is Cmax and all that stuff. But this is the basics of PKPD that all of you need to know before you take the examination. So PKPD is indices of time over MIC. Normally you would give a loading dose followed by a maintenance dose. Cmax over MIC, one large bolus dose. AUC over MIC, perhaps you would achieve by giving frequent dosing to these patients. So this is what I wanted to tell you about the MIC. Now you can see that normally if you give intermittent boluses 500 milligram every 8 hourly, you achieve this kind of a concentration. So if your MIC is between 2 to 4 to 8, now for the people who don't know, meropenem is sensitive if the MICs are less than 4. Please, you have to believe me. But between 4 to 8, perhaps you can use it. More than 8, they are labeled as resistant. Now you are dealing with a situation where most of the MICs that you get in your ICUs are more than 8. Does that mean that we stop using meropenem? So we have come out with novel means as to how to deal with that. So when we are talking about something like 8 to 16 of MIC, perhaps if you move from intermittent bolus to continuous infusion, you might still reach the 16 MIC of meropenem. We go down further and we see that when we give an continuous infusion of very high dose, you might still escape with a MIC of 32. And you can see that the time that you are achieving that MIC of more than 32 is for 40% of the dosing interval. This is the dosing interval on this side. So perhaps that is a rationale for using continuous infusions in the ICU. Unfortunately, these are the few data that is available to us in favor of continuous infusion. Somehow or other, clinically, most of the doctors when we talk about, they would still say that we are not fully convinced because we are not seeing our patients getting better. But this is the rationale for giving continuous infusions in our ICU. So with a prolonged infusion of 2 gram TDS sufficient, that is more than 40% of the time interval, T over MIC can be achieved for MIC as high as 32 microgram per mil. Now colistin is a different story. Now this is the landmark study which actually told us that if you use a 9 million unit bolus and then 4.5 BD, then perhaps you'll be able to achieve. Now the currency or the index for the PKPD index for the effect of colistin is AUC over MIC. AUC over MIC is between 12 to 24 for colistin. But if your colistin concentrations are more than 2, then you can jolly well extrapolate that the AUC over MIC is more than 24. So for the moment we are going to the concentration of the drug. So here we are targeting a concentration of drug of 2 milligram per liter. Okay, so what we are saying that when we are giving a 9 or 12 million units, we are achieving a concentration of more than 2, and that is getting sustained over that period of time even afterwards. And that is why we have gone in for a higher dose as a loading dose, and then 12 hours later we start with the 4.5 milligram bolus dose, and that is the rationale. We can see that the intermittent doses are 3 million unit doses, even if it was 9 million unit total in one day, but it was 3 million units 3 times a day. We were achieving the concentration of 2 almost up to 48 to 60 hours. And that is the reason why we had to go for a large bolus, and the next slide will tell you why. The problem with colistin is that of heteroresistance. When you give colistin to the patient, there are good many counts of bacteria which are going to die, but there are a good number of bacteria which is going to survive. And that is the problem, that in the first lot, you have to kill most of the bacteria. And that is why we have to give a bolus dose in these patients. So heteroresistance is very frequent with colistin, and that is why perhaps in that initial period to take care of these resistant bacteria, these are the ones which have responded. The resistant bacteria are the ones which have survived. So to take care of that, not only you need to give a very high dose of colistin, but perhaps you need to combine with certain drug, and that is where we come into combination therapy. So the combination therapy, basically we are looking at synergistic killing. It is something like synergistic killing is 2 plus 2 is not 4 but 5. So we are expecting that when you combine 2 antibiotics with 2 different mechanisms of action, possibly the net effect is more than the sum of the 2 together. And then obviously maybe because of that we could come down the dosage of each individual drug, and maybe we could get away with less side effects. So that is the basic principles of combination therapy, basically to reduce the toxicity, especially of polymyxin that we are using, aminoglycosides. Maybe we are shortening the duration because we would get an earlier clinical cure, and maybe we would get an improved microbiological and clinical cure. And then finally, the reduced speed of antibiotic resistance stays because we are exposing the patient to a shorter period of antibiotic. Probably we are not allowing the bacteria to gain resistance. So these are the few studies which have shown that the combination therapy, the mortality has come down significantly and over monotherapy, and that is why combination therapy is advised in extra ex-DRO patients in our ICU. And this particular data is for Klebsiella pneumonia Unfortunately, this Klebsiella pneumonia is not the one that we see in our ICUs in India. This is KPC pneumonia, and the pneumonia, Klebsiella pneumonia that we tend to see in our ICU has a different metallo-beta-lactamase, which is the NDM1. So whether I can extrapolate this data to my NDM1 Klebsiella is something that is debatable. I don't know. I don't know the answer to that. So you can actually go for combination therapy in severely neutropenic patients, in MDR, Pseudomonas and Acinetobacter, and add Klebsiella to that. And obviously in the empirical hit hard and hit early and hit hard rule that we follow in septic shock from bacteria such as streptococcal pneumonia. The other thing that we need to take into account is augmented renal clearance. Now we are dealing with, most of the time we are dealing with septic or septic shock patients. We need to realize that this is a state of hyperdynamic circulations. In the good old days when I used to put PA catheters, and I'm afraid none of you have been even exposed to, my residents, I showed him a PA catheter, he couldn't recognize it. It was really, a shock to me, but well, things move on, and maybe what I liked is not necessarily what you like. But in those days when I used to put a PA catheter, I used to get a cardiac index of 5, 6, that would mean a cardiac output of 8 liters, 9 liters, 10 liters. We all know what the normal are. And the SVR would be in the boots, 200, 300, around 800 to 1200 is the normal. And that is the kind of picture that you get in the septic patients. So obviously when the cardiac output is twice the normal, the renal blood flow is twice the normal. And if the renal blood flow is twice the normal, obviously the clearance of the drug is twice the normal. And then we subject our patients to renal replacement therapy, especially the continuous renal replacement therapy. Here again, the amount of blood that is presented to the filter is very high, and it's a very simple law of diffusion. When the concentration is high in the blood because of the antibiotics that you are given, and you are exposing it to a semi-permeable membrane, by a simple rule of diffusion, most of the drug is going to be washed out. So there are several conditions which would come into this augmented clearance category, and that is something that we need to be aware of, and that is why we need to know that the usual doses that we give to this patient may not be enough. Number one, because the volume of distribution in septic patient becomes very high. You know that they have a bounding pulse. A lot of it is accompanied by increased capillary permeability. So what all fluid is there inside the blood in the intravascular compartment is going and getting pushed into the interstitial compartment. And that is why you tend to have your ICU patients who are all boggy and swollen up at that time. So the increased volume of distribution makes these drugs distribute into a larger space. And then on top of it, more drug is getting cleared by the kidney. So the effective concentration in the blood, which is where you want it to be, is definitely going to be just a fraction of what you actually wanted. And that is why you need to think clearly as to what are you going to do about the dosage of the drug. And that is why you have to give very high doses, and I'll come back to that later. But before we move on to the next part, I need you people to become aware about what are the gaps or what are the holes in the spectrum of the antibiotics that we are dealing with. I'll just draw your attention to the last two lines there, carbapenems and colistin, which are the two favorite workhorses of most of you people in the ICU. Carbapenem does not deal with MRSA, C. diff, enterococci. Enterococci, normally we tend to treat them with vancomycin. If it is vancomycin resistant enterococci, we tend to treat them with linezolid. And one thing that I have not mentioned there is Stenotrophomonas maltophilia. A microbiologist sitting in the lab grows Stenotrophomonas maltophilia from a patient in the ICU would almost call up and say, how long has your patient been on meropenem? And he would say 14 days, sir. Not surprising. He is selecting out Stenotrophomonas maltophilia. So these are the things that you need to be aware of. The treatment of Stenotrophomonas maltophilia, the sensitivity to ceftriaxone or levoflox, maybe just to stop meropenem. 14 days is good enough time. You should have stopped it 10 days, 5 days back. Colistin. Colistin is something, again, we have been using colistin right back at center, and sometimes when the patients go back or go out of the ICU, they continue to receive colistin because nobody bothers to stop them. And what happens? We are growing fancy things like Providentia, Moraxilla morgani, Providentia, Serratia, Burke area patient. These are all clones of Pseudomonas. They were taught as Pseudomonas to me when I was a microbiology student. Now they are all variants of the Pseudomonas that have come up. But when they grow this, just look back into the drug chart and see how long has the colistin been there. So these are certain things that you need to know about. So to sum up shortly, when we go for an optimal selection, we have to factor in what is the presumed site of infection and address any surgically remediable pathology straight away. You have to make a distinction between the community-acquired pneumonia community-acquired infection versus a hospital-acquired infection. Obviously, your choice would be different, and for hospital-acquired infection, your choice will be based upon your hospital antimicrobial and maybe a discussion with your microbiology colleague. Optimal duration, I don't need to talk about it. As short as possible, but in any case not more than 7 days. Very rare cases probably you'll give it for 10 days, but there are instances where you have to give it for 4 to 6 weeks. So those instances we have already talked about. Barring those instances, perhaps in most of the cases that we do in the ICU, 7 to 10 days is more than enough. To summarize, ladies and gentlemen, for antibiotic dosing in critically ill patients have altered volume of distribution. We talked about the altered volume of distribution. And they also have an augmented renal clearances, and because of these two factors, they need larger initial doses to rapidly achieve therapeutic concentrations, higher doses or more frequent dosing to overcome increased drug eliminations. One more thing which I forgot to add, that most of the ICU patients have an albumin of 1.2, 1.3, 1.9. So they have low plasma albumin, and the low plasma albumin alters the protein binding of these drugs. So highly protein drugs like fluclox, cetapin, there obviously the more free fraction of the drug is available. So and obviously that gets cleared up. So there are reasons for us to believe that low protein could also lead to suboptimal drug concentrations. All this would mean that critically ill patients, the standard doses that you have been taught in your pharmacology books may not be effective. You have to think out of the box. You have to give higher doses. You have to give double the doses. Instead of 8 hourly, probably you have to give 6 hourly. Instead of 6 hourly, probably you have to give 4 hourly. You have to keep your eyes and ears open. Those days are gone. Fixed dose combinations are gone. You just have to look up your mobile, look what is the dose and give to the patient. I'm afraid that is not going to work. You have to make it more individualized to the patient's needs, and that is where now we are moving from evidence-based medicine to what is called as precision-based medicine, more tailored to the needs of the patient who is there actually at the bedside to whom you are treating. Thank you very much for your patience.
Thank you, sir. So now we have a short tea break and we'll reassemble after 20 minutes.